So I think we're going to invite all the previous speakers back. So we have a few questions from the audience and a few from ourselves. So I'll just start by asking the first question to Ellie. It's from Joe Galvin asking about, is there access to oocyte donation yet in the UK for women with mitochondrial cardiomyopathies?
Yes, so my knowledge about this is limited because I actually haven't come across this with one of my patients. But I understand that this is available in the UK. I believe it's just through a centre in Newcastle and might just be on a sort of research as part of a clinical trial. But I do think it is potentially available. How patients access this, I would need to look into it. But this is essentially what they were calling in the press the 3-parent babies, where you're able to keep the nucleus of the egg but replace the outer egg, so you have functioning mitochondria for people with mitochondrial conditions.
Thanks, Ellie.
Great. Ellie, just while you're speaking, we've got a question here from Catherine Moore, who's just started as a genetics counsellor with us in Leeds. Are there any implications for women with an ICC going through the IVF process?
Yes. So I don't work in a PGD centre, so I don't know all the ins and outs. But from my experience of patients who I've referred to the PGD centre, so the number one is sedation. So if a woman has an ICC, especially if she has an ICD, they have to be very careful about the sedation they give her when they're doing the egg retrieval. And another is with the treatment they give you to stimulate ovulation can sometimes be dangerous for patients, I think particularly women with heart failure. So they do need to do like a specific assessment if the woman has an ICC, but it is possible.
Okay. Mike, can I put something to you? So, I mean, the guidelines, the ESC guidelines are very welcome in the sense that they're very detailed. They give very expert guidance on how we should be advising our patients. There's a stress on them on this sort of systematic, structured approach to exercise prescription. And while I marvel at their scope and the detail, I also cower a little bit in my ability to deliver that level of detailed exercise prescription to patients in a busy clinic. Now, clearly, this is your field, and I'm sure you will. This is your sort of bread and butter. But for somebody like me, who tends to find those conversations quite challenging when you're trying to be restrictive to a patient, what would your tips be to us about how we practically have these conversations in clinic? How long does it take? How long would you set aside for this discussion? Bearing in mind we've got to talk about all the other elements that are relevant to the patient.
You're absolutely right, Stephen, that it can be quite challenging, and obviously how challenging it is will depend on the impact that your recommendation has on that particular individual. So if you've got a competitive athlete that you potentially suggest that he should not continue with competition, that discussion is probably going to take around half an hour. If you've got a regular HCM patient that you're simply advising on exercise, then that can take 5 to 10 minutes. I think the best approach is that you have to put some time aside. It does need, I think, for the time being to be consultant-led or someone who has experience in exercise prescription. I think you can be specific, but it doesn't have to be as detailed and specific as necessarily as I described in my presentation, in terms of someone who's interested in regular exercise for physical fitness. You can describe the moderate intensity of exercise simply by the way he's breathing, although I think most of them will have had an exercise test as well. And the other thing I wanted to say is that there is no point of you having a discussion with yourself without the patient listening, and that's where the negotiation comes into play, because obviously you can't take someone for point A to point Z on one consultation, and those consultations that involve individuals who've been exercising all their life, they do high intensity sports, I'm afraid, will take more than one consultation to come to an acceptable result. And it's usually a result of negotiation that you gradually bring him where you want him to be.
Okay. Thank you very much. I get that point. I mean, you make the point about it needs to be somebody who's experienced in exercise prescription. I think that's you, Mike, and certainly not me. But it's something I need to learn, and I get that. And I suppose my main point is that I'm highlighting that I think in the real world a lot of us don't do this very well. And we've got a lot to learn, and I could certainly benefit from some more detailed discussions with you about how to actually practically deliver it.
And you're absolutely right, and that's something that we do particularly badly because we start badly from the medical school. We've got very little sessions in terms of what's exercise prescription, cardiac rehabilitation, and then we're called to do that when it comes to our clinical practice. So I think the rule is, and it was for me as well up to about a few years back, that you do your consultation, you deal with your HCM aspect, you deal with the medication, and then you dread the question about exercise and hope that the consultation will probably finish before you come to that point. So I think there is a lot of work to be done, both from the British Association of Cardiovascular Prevention and Rehabilitation, as well as the European Association of Preventive Cardiology, because at the end of the day, it's an extremely important point. There is a lot of benefit to be gained from our patients with inherited cardiac conditions, given the progress that we've seen with the treatments that we provide and the near normal or population-based survival. So those individuals will go in their 40s, 50s, 60s, and 70s if we treat them in the right way. And you saw also the lecture from Professor Hugh Watkins regarding the potential impact, for example, of high blood pressure on top of hypertrophic cardiomyopathy or in the hypertrophy of the heart.
Okay, thank you, Mike. Just while we've got you on the floor, we've got a question here from Will Proctor. Do you encourage patients to wear or purchase wearable technology to help monitor and log their activity information? I guess Fitbits and the like.
Yes, so I was going to say it depends what do we try to monitor. So if we try to monitor physical activity, there are plenty of apps that can monitor that, and I think that's very advisable. And yes, I do encourage my patients, even my average HCM patient out there. I think we may come to a challenge though, and we realize that when we try to do that cardiac rehabilitation program as a research program, that very intense monitoring, particularly with devices that can record rhythm strips, like for example the Fitbits potentially, or the Apple Watches, may pose a challenge, because the main challenge that we identified is that you've got young individuals who will experience non-sustained VT. And the longer you keep monitoring them, the more you're going to identify. And then how do you treat the ESC risk protocol, which is based on a 24 or 48-hour Holter monitor over a year? So we need to be a bit careful, because I suspect, as it was the case in our study, that we'll start implanting a lot of individuals with ICDs if we go to ECG monitoring devices.
Absolutely, and I think that sort of indicates a big gap in our knowledge of what is the arrhythmia burden in all these diseases, and we pick these things up and we don't know what the frequency is. But my hunch is that we will be working towards sort of total arrhythmia monitoring, sort of equivalent to having a loop recorder in permanently. And if we can automate the analysis of that, then we'll know how frequently we see these arrhythmias and then how we manage them. But you're right.
I completely agree, and I think that's not a choice that we're going to have. That's going to happen. The technology is coming. It will be there, and we will need to get the data quite quickly if we are to avoid implanting a lot of ICDs unnecessarily in patients.
Yeah. Thank you.
Thanks, Michael. I've got a question for Maite. When you see women who've developed LV impairment in pregnancy, particularly if they present at the later stage, when you see them in the postpartum period, sort of what level of investigation do you go, and when would you consider perhaps gene testing in these patients?
I mean, it's such a dramatic presentation, you know. So in reality, if even the situation recover or doesn't recover, I treat them as the possibilities are all of them. So the use of genetic testing here could be very useful and I always treat this as a family, as it's not a woman only, it's a family and a family behind. So in reality, I'm very aggressive with investigations. So the goal here is to understand. The only thing is just to take it from the top. There is a lot of peripartum cardiomyopathy label that probably was an atrial arrhythmia with a little bit of ventricular tiredness at the end of pregnancy that was nothing else, and what needs an EP study. And so therefore, the truth is that you have to be very patient and take what it is, sometimes even doing family screening to find out what it was, and to review a lot of the data to actually try to see what the label was and what it is that might have been.
Thanks.
Great. Ellie, I've got a question for you from Josephine Affleck. What's your experience of couples using bespoke NIPD? I'm presuming that's non-invasive prenatal diagnosis. Did they go on to have an invasive test? And did they want a non-invasive test for info, or did they terminate the pregnancy on the basis of that result?
So I have limited experience of this because I only have one couple who's pursued this route. And what I normally do, because I work within cardiology, if someone's considering either PGD or prenatal testing, I refer them to their regional genetics service because they have better links with the organising those sorts of things. So the couple that I did refer for just further discussion at a regional genetics service were doing it to consider termination. So it was they had ARVC in the family, so it was testing for a desmoplakin variant. But I haven't had any updates as to whether they actually went ahead with that or not.
Okay, thank you. There's a comment here from Deirdre Ward from Dublin. They are piloting condition-specific written exercise prescriptions developed with the Sports and Exercise Medicine SPR. Wow. Perhaps we can share our experiences next year. So that's, I guess, one way in which we can try and integrate this into clinical practice for those of us who aren't expert in sports cardiology.
Go ahead, Maite.
No, I'm saying that Deirdre is in for next year then.
We had another comment from David Walker, who said they had a talk recently from the mitochondrial service in Newcastle, and they can do this, probably going back to the original question that was to you, Ellie. It just says, I'm not sure if they discriminate between different mitochondrial conditions, but in theory it could be available. Just
good to know.
Maite, can I ask you what your experience is of offering invasive gradient reduction therapy to women before they get pregnant to try and modify their risk? Could we, for example, reduce the risk during pregnancy by doing a myectomy or by doing a septal ablation before they get pregnant as a way of allowing them to have a family more safely?
Yeah, I mean, that's the ideal situation. So, I mean, when you have the chance, someone at a young age that present with a need a myectomy before fertile age, to be honest with you, either have a presentation of pediatrics, which you had required a myectomy before and maybe even hardware by then, or actually is something that has been undiagnosed. So if you had the chance, you would love to have the heart in the best condition. I mean, I had told you the beautiful outcome of this lady, but it could have been very different. It could have been very different. I mean, I can tell you how many hours we have been watching her to make sure that was absolutely fine. And so it is not ideal. So the truth is that there are many surrogates. I mean, think about it. This one already had a presentation of paroxysmal atrial fibrillations at the age of 28 with hypertrophic cardiomyopathy. So, I mean, obstruction is already having a deleterious effect on her. So if I would have grabbed her before, she would have upper tract obstruction treatment. Yeah. So ideally, all those things to be planned before.
Okay, but do we have it? Do we have enough evidence, or is it just anecdotal evidence to know that patients who have undergone myectomy or septal ablation can have a safe pregnancy?
Oh yeah. No, in that sense, for example, I actually did review this data on the past. So we don't have that many ladies with alcohol septal ablation before pregnant age. I had to say, because for whatever reason is not prioritized for that age group, or actually in this country. But we do have the whole series of pediatric patients that they come into age to have patients, and for those who have, and to be honest, the data is below 50 or something cases that I have been able to review personally, but they have done very well.
Okay,
great. Another comment from Jill Calvin. I think this is directed towards you, Michael. As only 10% of patients with HCM who will subsequently have a sudden cardiac death were identified as high risk by the ESC calculator, Marin et al. The ESC guidance seemed very liberal. Should MRI genetics not be involved in the decision before return to or continuation with exercise?
Yeah, I mean, I think that there is definitely a role for HCM and genetics. It's just I'm not sure if now it's the time for that role. What do I mean by that is that in terms of genetics, I don't think we've got solid evidence regarding particular genotypes that may increase your risk. We need to do more work on that. The actual recommendations for other conditions like arrhythmogenic cardiomyopathy, even dilated cardiomyopathy, they do mention specific genotypes that you need to be a bit more cautious. It's just we felt that at this point in time, that was not the case for hypertrophic cardiomyopathy, but I'm sure that that's what the future holds. Regarding the cardiac MRI, of course, we use it on a regular basis, but again, we need to be a bit careful because I mean, the evidence is a bit controversial. I think most of us will accept that if you've got a significant burden of myocardial fibrosis, excess of 15-20%, then that's a risk. Beyond that, we have to remember that up to 50% of HCM patients may have a bit of fibrosis, and a speckle of gadolinium enhancement on the MRI, I'm not sure that it should necessarily change the way you view risk stratification in hypertrophic cardiomyopathy. However, the point is that it's level of evidence C.
Okay, we've just got a couple of minutes left. It would be good for us to finish on time. So this is for you again, Mike, from Ian Williams in Norfolk and Norwich. In hypertrophic cardiomyopathy, is the issue of exercise regarding arrhythmic risk because of acute adrenergic drive or low-grade post-exercise myocardial damage or inflammation?
I think the honest truth is that we do not know. Both have been hypothesized. So there are questions regarding whether the exercise increases your actual risk. I have to say, it's not that we've got solid evidence that exercise increases the risk. The whole thing comes from the fact that we had the registries that demonstrate within the registry that hypertrophic cardiomyopathy seems to account for a high proportion of sudden cardiac death in elite sportsmen. However, on the other hand, to counteract that, to the specific question, as I saw, there are some animal studies that suggest the opposite, that exercise may reduce myocardial disarray, may prevent fibrosis, may reduce the expression of hypertrophy markers. And we also know that athletic individuals who have been exercising most of their life and then they develop hypertrophic cardiomyopathy, they tend to have an overall more favorable phenotype in terms of the cavity, in terms of the diastolic function, accepting obviously that those individuals are probably the ones who've been selected in terms of being able to exercise.
Great, thank you, Mike. Okay, well, we've reached past, so I think we'll end the session there. Thank you very much to all the speakers. I think it's been a superb session. I've certainly got some homework to be doing on those exercise guidelines, so I better get reading. And we'll see everyone back in half an hour for the keynote session. Thank you.
Thanks.